So good morning, ladies and gentlemen, friends and colleagues, and welcome to the Caristo Diagnostics Breakfast Symposium. My name is Stefan Neubauer from the University of Oxford, and I'm also one of the co-founders of Caristo. We have a fantastic program for you this morning, which we've entitled Measuring What Matters, Coronary Inflammation, Plaque and Cardiac Risk. We also have two outstanding speakers. The first is Professor Ron Blankstein, who needs no introduction, MSCCT past president, amongst many other things. He's from Brigham and Women's Hospital and Harvard Medical School, and he will talk about integrating coronary inflammation and plaque assessment to manage coronary artery disease. The second speaker, also needing no introduction, is Dr. Tim Fairbairn. There's something ringing here. Okay, he is from Liverpool Heart and Chest Hospital, and he will report to us his experience from real-world implementation of CariHeart and CariPlaque in clinical practice. So without much further ado, can I hand over to Ron for his first talk. Thank you.
Good morning, everyone. Thank you all for joining us so early. I think we're talking. This is going to be a really exciting session, a nice way to kick off the second day of the SCCT meeting. And we're going to talk about topics that are near and dear to my heart, which is prevention, inflammation, plaque, everything we want to learn about when we come to SCCT. And I'll start off with a talk about integrating inflammation with plaque assessment. One of the things that I think we have learned to recognize is that most individuals who experience a cardiovascular event have underlying risk factors. This is important because when patients come to the hospital, they experience an MI, they often are shocked. They're saying, how did this happen? I was the picture of health and this was out of the blue. But the reality is when we look backwards, almost always these patients have underlying risk factors. They just weren't recognized. And even when they're recognized, they're often not treated. We really don't do a good job around the globe treating the various risk factors that our patients have. And one of the reasons we don't is because we rely on risk scores. It doesn't matter which country and which continent you live on. There's probably a local risk score that's used in the US. It used to be called the Poole-Court equation to calculate a 10-year risk of ASCVD. We are now moving towards another equation known as the PREVENT equation. But in all these equations, we actually tend to underestimate risk in younger individuals, and sometimes we overestimate risk in older folks. So they work okay for populations, not always that precise for individuals. And that is a really important point. Now, the other point is inflammation. We're learning more about inflammation, and inflammation leads to plaque development. When we say why is it that some individuals develop plaque, one of the important risk factors, it's certainly not the only one, is inflammation. And it also leads to faster progression of plaque and ultimately plaque rupture, which is a process that leads to events. Why is it that some people have inflammation? Some folks are actually more predisposed. Maybe they have autoimmune diseases that cause inflammation. For some, it can be our diet that's pro-inflammatory, is all the processed foods. For some folks, obesity, which is prevalent around the globe now, is associated with more inflammation. So it is common. It's everywhere. There's toxins in the environment, depending on where we go. It's everywhere, and we're seeing this more and more. We've always said, well, inflammation is great, but can we really measure it? We used to rely on a C-reactive protein, which is a blood test, which is nonspecific. Just flying over here, I was probably exposed to some virus on the plane, and my CRP is a little bit higher. So it's a good measure. I absolutely measure it, but we always said, can we be more specific? Can we actually measure inflammation with imaging? And the answer was always no. We really don't have a good tool. And that is up until recently when we learned that we can actually measure inflammation on a routine coronary CTA using the fat attenuation index. It doesn't require any special processing beyond the regular coronary CTA that we acquire. The concept behind this is that our coronary arteries are surrounded by epicardial fat, and when there's inflammation, and that could be because of communication with cytokines between the adipose tissue and the coronary vessel, there's lipolysis, which is the breakdown of fat, and that causes local edema, as well as other signatures in the fat around the coronaries, and we can actually measure that. And ultimately, that leads to a measure known as 5-fat attenuation index. We'll talk about that in the next slide. But one of the things I want to introduce here is how important this can be for prognosis. And on the right here is the CRISP CT study, one of the earlier studies showing the prognostic value of this. This is all work of Harris Antoniadis in his group. And in this study, I'm not showing all the results here. I'm only showing the validation cohorts, including both in Erlangen in Germany and Cleveland Clinic in the US, showing dramatic separation here of risk between patients who have an abnormal phi or not. And one of the important things about this study is that it actually adjusts for risk factors, for calcium score, and for high-risk plaques. And even after you adjust for that, there's still separation of risk. That is really important because there's a lot of things out there that are associated with a higher risk. And the big question is always, yes, but does this add on top of calcium score? Calcium score is one of the best risk markers we have in prevention. Does this add on top of plaque? And that's a crucial point. So let's talk about what this phi score is. There's a lot of misconceptions out there about a phi. So first of all, when we just look at the Hounsfield unit, we can measure PCAD or PVAT, pericoronary adipose tissue or perivascular adipose tissue. And that certainly gives us a signal that there's something going on, that there may be some inflammation. But when we actually measure phi, we now report this in a measure that is corrected for the tube voltage. That is very important because, as we know, scan acquisition parameters are going to influence the Hounsfield unit. This is not as simple as sitting in front of your workstation, just drawing a region of interest and saying, aha, the Hounsfield unit is 71 Hounsfield, so this person has inflammation, and they do not. There is no such a thing as a Hounsfield unit threshold that tells you if there's inflammation or not. You have to use the phi score. It has to be corrected for the tube voltage. And I say phi score because once you have the phi, the actual phi score now corrects for other measures. It corrects for anatomical factors. For example, there's side branches of the vessels. You cannot do a big region of interest that includes a side branch. That's going to completely give you a faulty measurement. The other important thing about the phi score is that we can do this in every coronary artery, LAD, circumflex RCA, and there's corrections that need to be made for every coronary artery. So when we integrate the phi and we correct for these things, we get a phi score, and ultimately that can give us a percentile for our patient. We use the mean phi score, which is the average of the three vessels, and you get a percentile for that particular patient, so then you can look at their risk relative to other individuals of the same age and sex. Let's get back to prognosis, and this is a paper that I think everyone in the field of cardiac CT by now knows or needs to know. This is the Orphan study, in really a seminal study in the field of cardiac CT. So let's kind of dive into some of the things that the Orphan study has taught us. First of all, one of the important things and one of the strengths of this study, and why I think this is one of the most important studies in the field of cardiac CT, is the size of it. Anytime we validate any model, we need to have a large population. I mean, this is just one of the premises of AI. To have a good model, you need a lot of inputs, a very diverse population. And the Orphan study is targeting 250,000 individuals, so clearly one of the largest, if not the largest, coronary CTA cohorts in the globe. Now, for the study that was published in The Lancet, we currently have 210,000 individuals, and this first analysis was based on 40,000 individuals. But let's dive into one of the first results of Orphan, which I think is very important. And by the way, this slide has nothing to do with inflammation. This is a slide that I think is applicable to the entire field of cardiac CT. I have to say this, we're at SCCT, we're all here to learn about cardiac CT, so this is like a key slide. So in the Orphan study, first of all, if we look at the population, we're seeing a mean age of 59, 53% men, so a nice distribution of men and women in this study. If we look at the prevalence of disease, and this is not unique, we see this in a lot of cohorts, but people forget about this, that the proportion of patients with obstructive disease is actually pretty small, 18%. But it's the vast majority of individuals, 82%, that have non-obstructive disease. This is the most common finding. Anyone who reads CT knows most of the scans that we're going to read every day are going to be patients with non-obstructive disease. What about the risk? What is the risk that's associated with this? Shown on the bottom here on the left is the risk for cardiac mortality, on the right for MACE, which is a composite of death, MI, and heart failure. And what we can see, not surprisingly, is patients who have obstructive coronary disease have a higher risk. We see an adjusted hazard ratio of 1.4 on the left and an adjusted hazard ratio of 1.5 on the right. No surprise, if you have obstructive disease, you're going to be at higher risk. Maybe you have more plaque, maybe you just have more significant disease. But the question is, numerically, which group has more events? And if we now look at that, we can see that patients who have non-obstructive disease, just because it's a larger cohort, have twice as many events. That's true both for cardiac death. It's also true for MACE. So patients with non-obstructive disease, they have twice as many events. So most of our events in our patients are coming from patients who have non-obstructive disease. This is important because it reminds us that when we see a patient with non-obstructive disease, we can't just dismiss and say, oh, it's just non-obstructive disease. We don't really have to worry about that. This patient is doing fine. You know, if we did a stress test, or stress test is going to be negative as well. We really have to pay attention to this group. And one of the ways we can do that now is the PHI score. So shown on this graph here are the event rates where patients are divided by quartiles of increasing PHI. So the patients in red are the most inflamed patients. On the left, in the orphan study, the patients who have no obstructive disease. On the right, the patients who have obstructive disease. And we're going to show this now for every coronary artery just to make that point that abnormal PHI is important in every coronary. So here's the data in the LAD. The most inflamed patients have the highest risk. Here in the left circumflex, same message. And here in the right coronary artery, very nice separation of curves. And importantly, these curves don't just separate early on. They separate and they keep on separating over time, over a long follow-up. So that's important. Whenever you see curves that continue to separate over time, you know it's a really important risk marker. One of the things that's also really important, and this is being presented by Ken Chan at this meeting here, is the prognostic value of inflammation on top of the calcium score. Of course, calcium score, a very robust measure of risk, but if we look at calcium score divided on the left here by calcium score of 0 in red and going to increasing calcium scores from left to right here, at every level of calcium score, the more inflammation there is, the higher the risk. And even in a calcium score of 0, so if you have the patients who are most inflamed, they have the highest relative risk. Perhaps if we look all the way on the right here, patients with a calcium score over 1,000, the risk is going to be high no matter what, so no surprise that you're not going to see that increase in risk once you have that very high level of calcification. The other way to look at this is discrimination was a C statistic, looking at how this would discriminate. And if we look at a calcium score in AUC of 0.76, if we now add to that the mean PHI score, that increases to 0.82. For those who are not used to looking at these graphs, when you go from 0.76 to 0.82, that is a substantial increase in discrimination. We talked about that calcium score of 0. Another way to look at this is just look at the coronary CTA and say, does PHI predict risk in patients who don't have plaque or who have minimal plaque? And this was, I think, a very interesting result from the orphan study that's showing us that even in these patients, those who have most inflammation, again looking at mortality on the left or MACE on the right, have the highest event rate. I talked about PHI. We certainly talk about plaque analysis in this entire meeting. This is really a big theme of the meeting here is plaque analysis. And by the way, Caristo now has an FDA-approved plaque analysis tool. But these two measures are not in competition, and I want to make that point. These are complementary measures. If we want the best for our patients, we really want to combine both. We want to combine the plaque analysis, we want to combine measure of inflammation, and that's going to give us the best data for our patients. And it's not just a total amount of plaque. This is data on the right here, again, from that CRISP CT study, which I showed earlier on. In this study, they actually classified patients also whether they had a high-risk plaque. And for low PHI patients, maybe not a whole lot of difference. For high PHI patients, these are the higher risk. And if you add plaque to that, the curves separate as well. So combining information on amount of plaque, inflammation, and perhaps even high-risk plaque features, I think could all be important. I use the word perhaps because once we account for how much plaque individuals have, we still have an ongoing debate in the field. Do high-risk plaque features really add on top of that? But we'll save that debate to another session today. So whenever you hear of different parameters that increase risk, such as plaque, such as inflammation, today in 2025 you say, well, can't we just throw it all together and use some sophisticated AI process and that will be the best way to tell us which patients are at risk? And the answer today is always yes, if we can put it all together, but that's not an easy thing to do. But that's exactly what Caristo has done with this new AI risk model. In using this model, this is the Cari Heart device now. It combines together both the plaque analysis, it combines information about plaque, it combines clinical risk factors, and when you put it all together, it gives us an absolute and a relative risk for our patients that can guide management. And importantly, when you put together a fancy AI risk score, you really have to show that this works and validate it in different cohorts. And here on the right here are predicted risks based on this Cari Heart device here, showing in the different colors our patients are predicted to have low, high, and very high risk. And now let's plot on top of that the observed risk, because that's what you want to see, is that the predicted risk and the observed risk match up. And this is actually really a beautiful study because it showed that they match up perfectly. So this is really predicting something important, and the observed and predicted are very well aligned. So when we put this all together, I do want to walk through what is the information that today one might get from a Caristo report. And of course, Dr. Fairbairn is going to show some cases here to show this more. So first of all, on the left side here is the PHI score. We talked about the PHI score, and this gives us a sense of the amount of inflammation. And you can think about this as low to medium, high, or very high. So very high is when that PHI score is more than the 90th percentile. So let's say we have a patient who has a high PHI score. Then we move on the right side of the report. This is the Cari Heart risk. So this is a risk of fatal cardiovascular events. And again, this could be low, high, or very high. And this is using different thresholds that often are used in some guidelines. So for example, a low patient will have less than a 5% risk of fatal events. And if we combine this together, this is really the AI risk classification. In this example here, this patient, despite having a low risk of events, they have a high level of inflammation, high inflammatory risk, so they will have a high risk. And therefore, we would say this is really a patient we need to treat more aggressively. One of the things that I think is exciting, and this is probably a little bit more in the research realm right now, but it gives us a glimpse into the future, is the fact that we can track inflammation with treatment. This is always a big question. Can we use this to see which patients are responding to therapies? So certainly data showing us that when we treat patients with statins, we can see a reduction in the Cari Heart risk score, and this is driven by a decrease in inflammation. That's really what's being changed over time. We can also see in trials with a monoclonal antibody to oxidized LDL. This is ortikumab, showing a reduction also in the Cari heart risk in the patients treated with ortikumab as opposed to placebo, where there's no change at all in that score. And even a recent paper by Christoph Kostanidis and Harris Antoniadis showing that women treated with breast cancer, and we know cancer is very inflammatory and pro-inflammatory, have a reduction in Cari heart risks during treatment. An example here that I thought was interesting, I think I was talking to Harris one day and I said, you know what about colchicine? We're starting to use colchicine in the US now, it's FDA approved. Let's look at some patients who are treated with colchicine in PHI before and after. And in this particular patient, this is a PHI score of 9.5, and after 1 year of treatment, that PHI score goes down to 7.5. No other changes in this patient aside from being treated with colchicine. So I'm going to conclude my talk that PHI is strongly associated with incident cardiac death and MACE. Importantly, the risk is increased both in patients with non-obstructive and obstructive disease. That's a really key point. The PHI and also the AI risk score that's based on it, which is the Cari heart risk, can be added to any coronary CTA to identify individuals at higher risk of events who may benefit from more aggressive therapies. We can also identify individuals who may benefit from anti-inflammatory therapies. Currently, the main therapy that we use for inflammation is colchicine, but there are certainly many therapies in the pipeline for that as well. This data can be used to follow response to therapy, and this is something that's actively used now in several clinical trials. Thank you all.
Thank you very much, Ron, for a brilliant presentation. And we now move on to the second speaker, Tim Fairbairn. There will be some time for questions later on.
So good morning, everybody. My name is Tim Fairbairn. I'm a cardiologist from Liverpool Heart and Chest Hospital. So Ron set the scene beautifully, so I just have to continue this. I'm going to talk to you about a real-world application of using the CariHeart tool within an NHS England practice. So we were approached by NHS England to see really about how, if you use this CariHeart tool, an AI risk stratification in a patient's pathway, does it make any difference? And part of this was in relation to a NICE technologies evaluation. So we have 5 hospitals, of which mine is one, where we wanted to try to utilise the CariHeart risk tool in the patient pathway and see whether or not it made any difference. So I'm going to present to you some of the data. This is still ongoing, but we're going to present data up until May 2025. So as I said, these patients are individuals who have been referred into a normal chest pain clinic. They are going on and having a routine CT coronary angiogram as part of that assessment. And we wanted to understand, well, if you add in to their standard CTE report, a report giving their individual CariHeart risk, how does that make a difference? And we want to do this in a couple of ways. The first one was really to understand about how it impacted medical management or the physician or the clinician's response to having this add-in of the CariHeart risk score. And then the second component was really being patient-focused. So we wanted to see about how this influenced not just medication prescriptions from the physicians, but how likely does it make the patient actually be willing to take the medications and maybe change their lifestyle as well. So here are some of the results of the pilot study. So thus far we have 1,425 patients, and as you can see from data that Ron just showed, it's very, very typical of a patient population that are being investigated for chest pains or suspected coronary artery disease. So the average age was 60, a good split of female and male, 53 and 47. And what's really quite excellent, I think, about this pilot is if you look at the ethnicity distribution, so there's a high proportion of Southern Asian population, also Black population. So a really nice and varied population. If we look at the Q-risk score, so the Q-risk is the UK-specific cardiovascular disease risk score that uses factors such as where the patient lives, socioeconomic status, LDLs, age. And you can see from this that 3/4 of the patients were considered to be low or medium risk of a cardiac event in the next 10 years, so less than 10%. On the right-hand side, you can see what we would call the CT standard risk assessment. So, as I mentioned, we wanted to see about how the addition of this test made a difference compared to the standard assessments, so such as CT coronary angiography or the Q-risk score. So you can see that approximately 41% of patients had no disease at all recorded, 49% had non-obstructive disease, and 10% had obstructive disease. And obstructive disease was classified as a diameter stenosis of greater than 70% in this population. But as Ron has beautifully set out, we were really asking the team to do something quite different. So we were moving from a focus really of a diagnostic clinic to that of a preventative clinic and patients who were attending. And whilst they were all quite used to explaining patients the result of a CT coronary angiogram, be it the CAD-RAD scoring, they weren't necessarily used to having this additional information provided back to them. So we spent a lot of time really doing education in terms of writing guidance and spending time training the staff in how to understand, first of all, the FI risk and then the CariHeart risk score, and then finally how to interpret that, explain it to the patients, and then impact that in terms of management changes. So you've seen this before by Ron, but essentially we're just going to run over it because it's crucial. So the first thing is the FI risk score. So you can see in this individual that they have a risk that would be considered as high, so above the 86th percentile. Then you have their CariHeart risk score. So that was the inflammation score. Now we've got the actual risk of an event within the next 8 years. And in this individual, it's 4.6%. So that would be considered less than 5%, which is low. So, of course, the question from the staff is now, well, I've got high inflammation, but a low risk of a fatal cardiovascular event. So what should I do in terms of the patient management? Well, the flowchart and guidance that we provided them was that they should use this overall AI risk classification, which in this individual would be classified as high. So that would be either the instigation or the up-titration of their statin medications. So maybe the best way to explain this is through a few cases. So we're going to run through 3 cases now. So this is a typical patient, male, 52, diabetic, hypercholesterolemic, on good medications and well controlled in terms of their HbA1c and blood pressure. You can see from the CT coronary angiogram images that they have mixed calcified plaque in all three vessels, particularly in the LAD. If we add in this plaque analysis, you can see that the total plaque volume is actually relatively high for our population, so 182 millimeters cubed. The maximum stenosis was 40%. We add in the phi and the carry heart risk score. You can see that the phi score was low, and the carry heart risk score, again, of a fatal event was low. So this individual would be recommended just to remain on the current good medical therapy. What about this gentleman? So again, male, 53. This time he's a smoker, hypercholesterolemic, and he also has hypertension. His blood pressure is well controlled, and he's on his lipids are well controlled too, on appropriate medical management. You can see from the CT angiograms on the right-hand side that his circumflex and RCA actually appear pretty normal, but his LAD has quite a lot of mixed calcified plaque, with a probable severe stenosis in the mid-vessel. We look at the plaque assessment, and very similar to the last case, he has the same plaque volume, so 189 millimeters cubed. He does have a stenosis which is significant, so above 70% in the LAD. We add in the carry heart risk, so we have the phi score, which was increased, so above the 86th percentile, and a medium risk of a fatal event in the next 8 years, so 8.2%. Interestingly enough, you can see that the majority of the inflammation there is not in the LAD, but it's actually in the circumflex and the RCA. So this individual would be recommended for up titration of their medical therapy. So they had an increase in their atorvastatin up to 80, and they were referred on for further assessment to an interventional cardiologist for their symptoms and potential percutaneous intervention for the LAD. Now the final case. So we have a 46-year-old male. Sorry, they're all men. This gentleman said he got chest pains when he was stressed, so he felt it was non-anginal. He was probably right. He's an ex-smoker who's overweight with a BMI of 32, just on surgery medication. You can see that the CT coronary angiogram looks, well, pretty normal. So he was right, it wasn't anginal chest pains. Oh, sorry. But we add in the carry heart risk assessment, so you can see his phi score is actually high, so 83rd percentile. His carry heart risk is 1.8%, so low. So this individual, actually from having normal coronary arteries, would have a discussion about the potential instigation of obviously the lifestyle changes, but importantly, whether or not he would be considered for starting a statin therapy. So as I set out at the beginning, one of the key things that NICE asked and NHS England asked us was, well, okay, yes, how does adding in this risk score actually make a difference compared to what we would call our standard of care? And our standard of care and risk assessment for patients is the Q-risk score, so the cardiovascular disease risk score. But of course, these patients are all undergoing a CT coronary angiogram, so we have this additional information, which is the CT information. So here we can see a chart comparing the phi score to the CT risk stratification. And on the left-hand side, you can see that in this population, approximately 40% of patients, as I mentioned, were found to have no disease or normal coronary arteries. And of those 40%, 40% were actually identified as having high or very high inflammation. What about the non-obstructive population? Well, 47% of the patients who had non-obstructive coronary artery disease actually also had high or very high inflammation on the phi score. And of the patients who had obstructive coronary artery disease, 60% of those actually had low inflammation. So there's crossing over in all directions. What about if we look at the Q-risk score, which is the cardiovascular risk score, versus the AI risk classification? So you've got the Q-risk score on the left-hand side and the carry heart risk classification on the right-hand side. And very similarly, so whereby, as I mentioned, a lot of the patients were classified as having low or medium Q-risk score, cardiovascular risk score. 51% of these patients were actually reclassified and going to a higher risk classification using the AI tool. And of the patients who were in the sort of the high or very high risk score were classified, about 54% of those were reclassified from having high Q risk to very high risk categorization using the AI score. So how did this change patient management, so the physicians or the clinicians' decision-making process? Well, as you could see by the fact that we've identified a lot of patients who were previously by the standard care, be it CT or Q risk, of being a relatively low risk to being a higher risk, what this resulted was a change in patient management. So approximately half of the patient had some change in their management. And this was principally either the instigation of a statin or the increase in a dose of a statin therapy, with some change in aspirin therapy and a small percentage of patients being instigated on colchicine or ezetimibe. And we see this importantly across the board. So this was seen in patients who had normal coronary arteries, non-obstructive and unobstructive disease. We saw the same pattern, which was that patients were prescribed more statins. So you can see here that only 1 in 5 patients in actual fact weren't on a statin after being assessed with the coronary heart risk score. And we saw an increase in the intensity of statins, so from moderate to high intensity statins. So we're talking atorvastatin 40 or 80 or Rasuva 20 or 40. And you can see from this data that over half of the patients actually were on a high intensity statin. So is this consistent with other observations that we've seen in the real world? Well, the short answer is yes. So the UK observational study, so 45% change. Another UK observational following NICE guidance, a 39% change in treatment decision making, and a US observational study showing a 45% change in treatment decision making. So between about 40 and 50% of the time, this will result in a change in the patient's management. Key to this design, though, and one of NHS England's focuses, was that we had to understand how this impacted the clinician's understanding and attitude towards receiving this report, and the patients as well. So what we did is we designed a specific questionnaire for the healthcare professionals and for the patients. And we ranked it from 1 to 5, essentially, the questions, so 5 being extremely useful and 1 being not particularly helpful at all. And you can see from the results, on average, I think it was a 4.4 out of 5 score, that the clinicians found that the addition of this coronary heart risk score in the patient's pathway helped them understand the cardiovascular disease risk compared to the things that they were used to, so the coronary artery calcium scoring or the Q risk score. It made them more confident and happy about instigating changes in terms of recommendations for medications. But also importantly, they found that it actually not just helped their understanding of the patient's risk, but it also helped communicate those results to the patient and the patient's understanding of that risk. And what about the patients? Because they are the most important person. So again, a similar format of questionnaires in terms of the scoring system. And you can see that the provision of the coronary heart risk score really did help them understand their individual risk of cardiovascular disease and future events. It made them more likely and more willing, they said, to make changes in terms of lifestyle changes, but also be willing to contemplate taking a medication and being compliant with that medication. And that overall this had a very positive impact on their heart health. So, to conclude, you can see that the coronary heart, or the addition of the coronary heart analysis tool into a patient's pathway, identified a significant number of patients who were identified as higher risk compared to the standard approach, which was a Q risk score and a CT coronary angiogram. Because of this, we resulted in a significant change in patient management, with principally an increase in the number of patients being prescribed a statin and the intensity of the statins, so that 81% of patients, in actual fact, at the end of this, were on some form of statin therapy. And overall, the feedback from both the healthcare staff and the patients was that the addition of this AI tool in the healthcare pathway, in terms of understanding risk, was extremely helpful in them being willing to take their medications and being willing to accept a change in medications and be compliant with lifestyle changes. So thank you very much for your attention.
Thank you very much for also a very excellent talk. And if I could ask Ron to come up to the podium as well. So we now have 10 to 15 minutes for questions. We've got a microphone over there. So please come up and ask your questions. We have a first one right here.
Mahfouz Shah, Sarasota, Florida. I'm very pleased to see that happening, since this area of our interest for the last 20 years. We're probably the first to point out that epicardial fat tissue is an endocrine organ producing a lot of hormone, including local angiotensinogen, which create more the inflammation. And we have already published data that correlate increased epicardial fat volume, correlate with the Rasmussen risk score, which was put by Dr. Jay Cohn, about vascular elasticity, C1, C2, CIMT, etc. And furthermore, we have already pointed out that post-menopausal women have increased epicardial adiposity, and this might be account to the atypical chest pain syndrome. We also reported that there's a cohort of patients who have very high calcium score, very high in the 3,000 range when the epicardial fat volume was normal. There was no obstructive coronary artery disease. I think epicardial fat volume, not actually epicardial, is a misnomer. Perivascular adiposity, not just the epicardial, perirenal, because they have the same messenger RNA. They are really very important to look at, and they precede calcium score and time to look to epicardial fat as the real risk, not the calcium score, that's a late stage of inflammation.
Thank you. I think that was a comment, right? Okay, good, excellent. Other questions? Maybe while you're thinking of questions, I can ask both the speakers. So who do you think are the patient characteristics that will benefit most from this test, or is it everyone? Maybe Ron to start, and then Tim.
Yeah, I think it's two main kind of groups. One group is patients that you're interested in kind of more precise risk assessment, maybe because you're uncertain. Certainly patients are very low risk and you know they don't need to be treated fine. Patients are very high risk that you're already treating fine, but there's a lot of people in the middle that we may be uncertain about their level of risk and we want a more precise one. So I think it would be that, and that's a lot of patients who are referred to us. The other one, if we're thinking specifically about the use of anti-inflammatory therapies, they still haven't been kind of widely used. You know, colchicine is a selected therapy that we use for some of our patients. So if we're thinking, is this patient, perhaps the reason why this patient is having events or has plaque is because they have underlying inflammation. If we want to understand that better, I think it would be a good test for that. Okay, and Tim?
So I think it's important to remember that during the pilot, we were using it in patients who were coming to have a CT coronary angiogram as a part of their routine healthcare test. And I think that's the first thing to point out, that it's potentially appropriate for those individuals. Because what we're trying to do is use as much information as we can do from the test they're already having to change their lifestyle and risk over time, because as Ron pointed out, that we know that the conventional risk scores are not that accurate. And what we wanted to really change was a direction from just being a diagnostic, you know, interested in the 1 in 10 patient who's going to end up having a PCI, to actually the other 9 patients and really giving them that information to change their lifetime of risk. So in that aspect, I think that population is a very appropriate one. You can discuss more about the categorization once you've got the CT result, you know, which patient's going to benefit from the most. You could argue that the obstructives are not going to get a huge benefit because they're going to be on a high-dose statin, certainly at the moment in UK practice. But what about the normals or the very minimal disease? I think those are probably the most interesting to me, because as we could see that a high proportion of those actually were identified whereby before they would have been told, don't worry, go away, continue your normal lifestyle. In actual fact, now they're having a discussion which is you need to alter your lifestyle and potentially consider being on medications as well. So for those, I think it's the most interesting.
Thank you. Now, Carlos Rochit, who is actually the current SCMR president. Great to see you here.
Thank you for the introduction, Professor Stefan. First a comment, and congratulations to the leaders in the field. This is much needed. 2 questions. One is, in real practical, real life, once patient has a plaque, at least we're going to start statins, where it come from. So what is the percentage of patients that have high and very high risk at Caristo score that has no visible plaque at all, that we could benefit, I think, from this risk score? The second is a kind of a more high-level pathophysiology that I'm curious to know how the leaders are thinking on the working hypothesis that are working. Is inflammation all bad always? I mean, of course, if you have high-level inflammation, that will be totally bad. But I think everybody here has seen like a patient of 9 years old with 6,000 of calcium score and had never had anything in his life or her life. And so probably that plaque would pass through a lot of phases, and I think inflammation or some degree of inflammation would be part of the healing of the plaque. So it's more like an anti-inflammatory thing that we have to look forward in the future, or a modulation of inflammation that will be more important. What do you guys think on that?
Thank you. Maybe I'll just answer the first question, because that is in the Lancet paper. So about a third of the patients in the paper had no plaque at all. And in those patients, the phi score still predicted events with a hazard ratio of about 10. So it was very powerful in those individuals. In terms of, is inflammation always bad? It's probably a question for Ron.
Yeah, Carlos, it's a great question. I think there's kind of this balance in our body, like everything else in homeostasis, that it's both good and bad, and you need to have kind of the right balance. So certainly we need inflammation to fight infections and to kind of make sure in our body there's some protective aspects to it. So I think if there's dysregulation of that balance is where things are. But when we're looking at inflammation in the coronary arteries, whether it's by measuring CRP as a very crude surrogate or was this, we're really thinking about patients who have chronic exposure to elevated inflammation, not the one time they got something and then they have some local inflammatory process and it heals and they recover and they have some leftover calcium, which is what you're alluding to. So we're really trying to identify folks who have kind of chronic inflammation, repeated exposure over time.
And I think that's a really important point in terms of, if the patient has a bit of flu a few days beforehand and they come and have a scan, is it temporal? And then are you changing their complete... the lifestyle I don't think matters because good lifestyle is always good, isn't it? But instigation of medications for a lifetime, potentially because you're not bringing them back and checking them, or certainly not in our healthcare system. So I think that temporal is really important. And the pilot would support the orphan study. We had 40% of 40% essentially who were at risk from having normal coronary arteries to being higher inflammatory risk.
Okay, next question, please.
Hi, my name is Yasmin Hamarani from Rutgers University, New Jersey. It may be a dumb question, but I would think that FAI index is impacted by obesity. So if somebody's obese, to what extent, even if you're not inflamed, would it impact your FAI score? And we talk about if the abdominal fat, if the fat is more in the abdomen versus, lower extremities, how would that impact it? And the second question is, we have looked into pericardial and epicardial fat, and how much does it impact presence of coronary calcification or coronary plaque? So have you looked at correlation between epi or pericardial fat and the FAI index, and does it increase your risk of having events? Thank you. Yeah,
so on the last question, it is one factor that contributes to this, but it's really only one factor of many, many that goes into this calculation. The first question was what again?
So the obesity, body obesity, impacting FAI score and distribution of body fat and the FAI
So again,
index.
the FI score is fully corrected for BMI, for that patient characteristic. For the actual distribution of the fat in the body, that's not yet in the index, but we're constantly, improving that in the iterations that are coming up.
Yeah, and it was a great question.
Yeah.
And I would add to that, it's hard not to also comment on the fact that we now know that GLP-1 receptor agonists, which whether it's by losing weight or perhaps by other mechanisms, are very potent at lowering inflammation as well. So I think there's certainly an important intersection there.
Next question.
Sanjay Rajagopalan, Cleveland, Ohio. Great presentations. I'm wondering whether you could shed some light. We've done some work on iodine confounds that we published a few years ago. And one question that's always sort of intrigued me is how do you put this from a pathophysiologic construct where, admittedly you're controlling for the iodine, obviously contrasts to your index. But from a pathophysiologic perspective, there's also the idea that periadventitial vascularity and fragility of those vessels, which obviously contributes to leakage of those vessels, are fundamentally important in unstable plaque syndrome. So there's a lot of pathophysiologic literature suggesting that the more perivascular networks you get these fragile vessels that tend to bleed, and you get hemorrhage into and around the vessels. So this idea sort of flies in the face of this concept because, admittedly, when you have more perivascular vessels, you'd have probably more iodine and sort of goes in the opposite direction of the fat attenuation index. So, or maybe it does go in the right direction. So can you put this together from the perspective of iodine confounds, perivascular leakage, and how do you formulate sort of a coherent hypothesis that brings together what people observe, what pathologists observe, and what you see from the concept? Because it's not all inflammation. Obviously, there's contrast getting into the vasculature as well. So any thoughts on that?
Well, first of all, we don't have histology on these patients.
Oh, sure.
These are very large databases that have shown that this index, as it is developed, is very powerful in terms of, I think, the directional change. If you have some contrast going into the perivascular adipose tissue, that goes in the same direction of making the index worse. So I think it would simply underscore that there is an issue with increased inflammation vulnerability, so it might actually enhance the power of the index. So I think it makes sense from that perspective. Any other comments on that?
No, I agree, Sanjay. Very, very insightful question. I guess both would contribute to an abnormal measurement there and an abnormal phi, and maybe they can really occur together because inflammation would increase that permeability. So
Yes.
maybe we're all talking about the same process.
Yes, I know, but the focus always is on inflammation, where perhaps there could also be some construct and attention given to perivascularity, because this could be capturing that phenomenon as well, and this could bring together a more holistic understanding of how phi, which everybody says inflammation, but maybe it could be also related to the fact that there could be perivascular leakage, perhaps.
But the information is fluid, isn't it? So, I mean, I think it would be very consistent with what you're saying. So.
Thank you.
I also guess that leakage might be more in the acute processes, I would think, as opposed to chronically. But good comment.
So now the last question, then we've run out of time.
Yeah.
Hi, Vicky Loescher from Mount Sinai, Miami. Great talk, thank you, an eye-opener of the meaning of negative coronary CTAs for all of us. The question I have is a little bit out of the scope of prevention. Just for fun, have you guys assessed this index in patients with coronary vasculitis just to see like baseline inflammation and response to therapy? I'm thinking particularly of a couple of my patients with IgG4 vasculitis that maybe would have benefit of this.
So I'm out.
assessment.
We just use it in routine patients. Sorry.
So I think we have some anecdotal evidence. Maybe what comes closest to your question would be a cohort of patients with psoriasis, which is a systemic inflammatory disease. And Nehal Mehta has shown that those patients clearly also have increased phi scores and increased risk. So that information is available. But otherwise, it's a great suggestion for a systematic, larger study.
So I'll say we have some really good anecdotes from Brigham and Women's Hospital, which of course is Vicky is a former trainee of our program, but Dr. Weber, Brittany Weber, who runs our cardio room program, she sees exactly patients like that with vasculitis and in autoimmune conditions, and we have evaluated patients before and after treatment, and we see a reduction in the phi signal. And some of the most abnormal cases we see are precisely patients like the one you're describing. So certainly in those unique cases, we see very powerful signals.
One other comment to make, in the Lancet paper, in the supplement, there's actually a table that looks at the subgroup of patients with autoinflammatory conditions, and here again the index is highly predictive.
Awesome, thank you.
Yeah. So that brings us to the end. I again want to thank very much all the speakers, discussants. Thank you very much for coming, and I hope you enjoy the rest of the day.